In the mid-1930s, psychiatry was a precarious field. Mental illness was poorly understood, and the methods used to treat it were often crude, experimental, and sometimes outright barbaric. Patients suffering from severe depression, schizophrenia, or obsessive-compulsive disorder were frequently confined to asylums, where they were subjected to treatments ranging from isolation to electroconvulsive therapy. The boundary between therapy and torment was thin and perilously ambiguous. It was within this grim context that Egas Moniz, a Portuguese neurologist and politician, conceived an idea that would alter the course of psychiatry forever, a procedure that promised relief but carried the potential for devastation. Moniz, born in 1874, was a respected figure in Lisbon's medical and academic circles. He had a sharp intellect and a relentless drive to explore the human brain, influenced by the contemporary belief that the frontal lobes were the seat of higher cognitive functions and personality. The medical treatments of his time offered little hope to patients suffering from chronic psychiatric disorders, and Moniz sought a solution that would be both scientific and revolutionary. His approach would ultimately take the form of prefrontal leucotomy, what the world today knows simply as the prefrontal lobotomy. The concept behind the procedure was deceptively simple in theory, but terrifying in practice. Moniz believed that psychiatric symptoms were the result of disrupted neural connections within the frontal lobes of the brain. By severing these connections surgically, he theorized, the symptoms could be alleviated. While the theory might have seemed elegant on paper, the practical execution was anything but. The first documented procedures were performed in 1935, with Moniz and his colleague Almeida Lima selecting patients suffering from severe treatment-resistant psychiatric conditions, patients whose mental anguish had rendered them incapacitated for years. The tools used were crude by modern standards. Moniz designed a leucotome, a long, thin instrument resembling an ice pick, intended to penetrate the brain tissue through small openings drilled into the skull. In later experiments, a version of the tool was inserted directly through the eye socket, bypassing the need for large surgical incisions. Anesthesia was rudimentary. In many cases, it consisted of minimal sedation, leaving the patient awake and often terrified during the operation. Patient reactions were harrowing. Diaries, case notes, and hospital records from the time describe scenes of panic, confusion, and terror on the operating table. One patient, a woman in her 30s suffering from obsessive-compulsive disorder, reportedly begged the surgeons to stop as the instrument was inserted through her eye socket. After the procedure, she emerged unable to recognize her own family. Her personality flattened into a monotone, docile state. Another patient, a man afflicted with violent mania, became passive and vacant, a mere shadow of the person he had once been. Moniz, however, in his clinical reports, focused almost exclusively on the reduction of agitation or the diminishment of overtly destructive behaviors. The emotional and cognitive damage, extensive as it was minimized or omitted entirely. From scientific publications, Moniz published his first results in 1936, framing the procedure as a groundbreaking medical achievement. He emphasized improvements such as reduced aggression, calmer demeanor, and the disappearance of obsessive behaviors. Yet even at this early stage, the discrepancy between the clinical reports and the lived experiences of the patients was stark. Families documented drastic personality changes. Once vivid, expressive individuals became emotionally muted. Articulate minds were dulled. Independent thinkers became compliant and dependent. The ethical implications were profound. Moniz's patients had little understanding of what was being done to them. In most cases, consent was nominal at best, coerced or mediated through family members desperate for any hope of relief. Despite these alarming realities, Moniz's work quickly drew attention across Europe. Psychiatry at the time was desperate for solutions to chronic mental illness. Institutions were overcrowded, understaffed, and facing immense societal pressure to find methods of control or treatment. In this context, the idea that one could surgically intervene in the brain and produce a calmer, more manageable patient was irresistible. The horror of the procedure itself, its invasive, irreversible nature, was largely overshadowed by the promise of progress. Archival photographs and clinical drawings from the 1930s offer a haunting glimpse into this early era of lobotomy. Operating theatres in Lisbon were sterile but austere. Surgical instruments, though rudimentary, seemed designed for cruelty as much as for medicine. Case files often included notations such as "patient calm post-procedure" or "symptoms partially alleviated," with no mention of the profound emotional flattening or the catatonia that followed. In some diaries, patients described waking from surgery with a sense of alienation, unable to reconcile their internal selves with the body that remained. Moniz's experimental success was inextricably linked to his charisma and meticulous documentation. His reports were methodical, precise, and scientific in tone, emphasizing observable behavioral changes while omitting the human suffering. Yet, contemporaneous accounts from nurses, family members, and occasional sympathetic colleagues paint a far grimmer picture. Patients who had once been vibrant became shells of themselves. Those with expressive intellects or rich emotional lives were reduced to repetitive, vacant motions. The human cost was almost entirely invisible in Moniz's published papers. It is crucial to understand the wider medical and social environment that allowed this procedure to flourish. In the 1930s, psychiatry was dominated by theories that we now consider rudimentary or misguided. Psychoanalysis, though influential, was slow to provide practical interventions for severe mental illness. Institutional care often focused on containment, rather than cure, and overcrowding in hospitals created a desperate demand for rapid, tangible results. Within this framework, Moniz's radical intervention seemed both innovative and necessary. The idea that a physical, surgical solution could solve intractable mental suffering was compelling, yet deeply dangerous. By the late 1930s, news of Moniz's procedures had begun to spread beyond Portugal. Academic papers circulated in European medical journals, attracting both curiosity and skepticism. Some psychiatrists hailed the prefrontal leucotomy as a revolutionary breakthrough, praising its ability to reduce aggression and stabilize patients previously considered untreatable. Others recoiled at the barbarity of the method, questioning both the scientific basis and the morality of severing connections within the human brain. These debates, however, did little to stem the tide of interest. The allure of a seemingly definitive treatment outweighed the moral and ethical concerns, and the stage was set for a far more expansive and infamous chapter in lobotomy's history: its transplantation to the United States and the rise of Walter Freeman and the transorbital ice pick technique. The psychological ramifications of these early experiments were profound and disturbing. Many patients emerged emotionally blunted, incapable of complex thought or feeling, and unable to engage with the world as they once had. Families recounted horror stories. Sons and daughters who had once been intelligent and articulate became passive and childlike. Mothers reported that their children, once lively and expressive, now stared blankly for hours, unable to connect or communicate. These accounts highlight the fundamental ethical problem at the heart of Moniz's work. While the procedure may have alleviated outward symptoms, it did so at the expense of personality, autonomy, and human dignity. Moniz's experiments, however, continued largely unimpeded. The combination of scientific ambition, social desperation, and a lack of regulatory oversight created a perfect storm for the proliferation of a procedure that was, in essence, as brutal as it was experimental. Early patients were treated as subjects in a clinical trial whose human consequences were secondary to the promise of scientific advancement. Letters and diaries reveal the terror, confusion, and helplessness of those subjected to these procedures. Yet these narratives were largely overshadowed by the medical literature, which celebrated the procedure's successes while minimizing its horrors. Even today, the legacy of Moniz's work is deeply unsettling. The prefrontal lobotomy represents a moment in history when the pursuit of medical progress eclipsed the fundamental rights and dignity of patients. It serves as a stark reminder that scientific curiosity, when untempered by ethics and empathy, can result in profound and lasting harm. Moniz would go on to receive the Nobel Prize in Physiology or Medicine in 1949, cementing his place in medical history. Yet the stories of the patients, their suffering, their lost selves, remain a haunting testament to the human cost of innovation. The birth of the lobotomy was not merely a scientific milestone. It was the beginning of a horrifying chapter in human experimentation. It demonstrated how ambition, combined with desperation and a lack of oversight, could transform the human brain into a site of experimentation with catastrophic consequences. The early experiments in Lisbon foreshadowed what was to come in the United States, a rapid industrial-scale application of lobotomy that would shock the world with its audacity and its cruelty. By the late 1930s, the prefrontal leucotomy, conceived by Egas Moniz in Portugal, had begun to attract international attention. While European psychiatrists debated its ethical implications, in the United States, the procedure found a new and far more aggressive life under the guidance of Walter Freeman, a charismatic, controversial neurologist who would become the face of the American lobotomy craze. Freeman, born in 1895, was fascinated by the human brain and driven by the same desperation to find treatments for severe psychiatric disorders that had motivated Moniz. Yet Freeman's approach differed dramatically. He sought a method that was fast, replicable, and, he believed, scalable to the countless patients confined in overcrowded asylums across America. Where Moniz had relied on careful surgical intervention, Freeman aimed to industrialize the procedure, creating a technique that would eventually be performed in mere minutes. In 1936, Freeman met James Watts, a neurosurgeon at George Washington University Hospital. Watts brought technical surgical expertise, while Freeman contributed vision, charisma, and a flair for public attention. Together, they adapted Moniz's European procedures, initially using conventional prefrontal lobotomy techniques. But Freeman's restless ambition led to the invention of the transorbital lobotomy, a procedure so rapid and invasive that it could be performed in clinics without the infrastructure of an operating theater. The procedure involved inserting a sharp instrument, a modified ice pick, through the patient's eye socket, breaking the bone separating the eye from the frontal lobe, and then moving the tool to sever connections in the frontal cortex. The entire operation could be completed in under 10 minutes. The horror of the procedure was compounded by Freeman's disregard for patient experience. Anesthesia was often minimal. Some patients were sedated with electroconvulsive shock therapy to induce unconsciousness. Others received only brief sedation. Records from asylums describe patients screaming, thrashing, and pleading as the instrument was inserted behind the eye. Nurses and staff were forced to restrain patients while Freeman, often in a theatrical display, worked with precision and speed. The ice pick method became a spectacle of surgical efficiency and cruelty. Freeman's ambition was matched by a relentless drive to promote lobotomy as a solution to America's psychiatric crisis. Hospitals were overcrowded, staffing shortages were severe, and families desperate for relief clutched at any promise of improvement. The public narrative, carefully crafted by Freeman and his supporters, portrayed lobotomy as a miracle cure, a surgical intervention that could transform violent, unmanageable patients into calm, manageable individuals. Media coverage was sensational. Photographs of calm, seated patients, smiling post-procedure, were widely circulated, masking the grim reality. Many patients emerged apathetic, emotionally blunted, or physically debilitated. The patient population subjected to Freeman's procedures was vast and diverse. Records indicate that thousands of men, women, and children across the United States underwent lobotomies during the 1940s and 1950s. Women were disproportionately affected. Some estimates suggest that more than 60% of American lobotomy patients were female, many diagnosed with depression or anxiety. Psychiatric institutions, overwhelmed and underfunded, often saw lobotomy as a practical solution to chronic overcrowding. In some cases, patients were admitted for minor behavioral issues or social nonconformity, only to emerge with shattered personalities. One of the most shocking aspects of Freeman's work was his willingness to bypass surgical norms entirely. He performed procedures in hospital rooms, outpatient clinics, and even makeshift operating spaces, often without sterile environments or full surgical teams. Newspapers at the time occasionally reported on these expeditions, framing them as pioneering medical missions. In reality, the procedures were rife with risk. Infection, hemorrhage, and death were constant threats. In some documented cases, patients suffered severe hemorrhaging behind the eye or permanent vision loss. Others experienced seizures, profound cognitive decline, or complete apathy. The psychological toll on patients and families was immense. Diaries, letters, and interviews from survivors recount a terrifying mixture of hope, fear, and despair. One woman, subjected to a transorbital lobotomy for chronic anxiety, described returning home like a ghost, unable to feel joy or sorrow. Her relationships with family members permanently altered. A teenage boy, admitted for behavioral issues, emerged listless and unresponsive, his ambitions and personality erased. Families struggled to reconcile the hope they had placed in the procedure with the devastating reality. Despite these documented horrors, Freeman remained unapologetic. He traveled extensively, demonstrating the procedure at hospitals across the United States. His public persona was a mix of physician, showman, and crusader. He often performed surgeries in front of crowds of medical students or hospital staff, emphasizing speed and apparent efficacy. One notorious photograph shows Freeman wielding the ice pick with a triumphant expression. A patient immobilized beside him, a stark image of both innovation and brutality. The ethical failings of Freeman's work were compounded by the regulatory environment, or lack thereof. In many states, psychiatric hospitals had minimal oversight, and informed consent was poorly defined or non-existent. Patients were often unable to refuse the procedure, and families were pressured into signing consent forms without fully understanding the consequences. Legal challenges arose only sporadically, and by the time criticism mounted, thousands had already undergone irreversible surgery. Medical literature from the period reflects a disturbing tension. Scientific enthusiasm for the procedure was high, yet case reports frequently noted severe adverse outcomes. Some studies claimed behavioral improvement, citing calmer patients or reduced institutional management challenges. Others, however, documented catastrophic results: emotional blunting, apathy, cognitive impairment, incontinence, and death. In some instances, lobotomy was performed multiple times on the same patient, compounding trauma. Freeman's obsession with speed and accessibility led him to modify the procedure repeatedly. He developed the Freeman-Watts prefrontal lobotomy, a standard surgical approach, and then, more controversially, the transorbital technique, which could be performed in outpatient settings. Patients were immobilized in chairs, instruments inserted through the eye sockets, and brain tissues severed with a swift lateral motion. The procedure, lasting mere minutes, became a template for mass application, emphasizing volume over safety. The scale of Freeman's operations is staggering. Estimates suggest that he personally performed over 3,400 lobotomies during his career, while training others who carried out thousands more. Institutions across the United States, from large state hospitals to small private clinics, adopted the procedure, sometimes using it as a tool for social control rather than therapeutic intervention. Children, adolescents, and institutionalized adults were subjected to surgery for behaviors now considered normal or manageable. Individual stories underscore the human cost. One young woman, diagnosed with depression after the death of a family member, underwent a transorbital lobotomy and emerged incapable of forming emotional connections, her once vibrant personality erased. A middle-aged man admitted for obsessive-compulsive behaviors became apathetic and incontinent, losing both autonomy and identity. Letters from nurses recount patients staring blankly at walls for hours, unresponsive to stimuli, while others describe seizures, paralysis, or death following surgery. These personal tragedies were largely overshadowed in the public narrative, which emphasized supposed clinical successes and Freeman's celebrity status. Critics eventually began to speak out. Psychiatrists, neurologists, and ethicists highlighted the procedure's devastating consequences, questioning the scientific rationale and ethical basis for mass application. Some families initiated legal action, and investigative journalists exposed cases of extreme abuse and negligence. However, the procedure's popularity persisted into the 1950s, driven by institutional demand, media portrayal, and Freeman's relentless advocacy. The cultural impact of lobotomy in America was profound. It reinforced the notion that mental illness could and should be fixed through surgical intervention, often with little regard for patient autonomy or long-term consequences. The procedure became a symbol of the mid-20th century's fascination with scientific control over the human mind, reflecting both medical ambition and societal anxiety about deviance, mental illness, and institutional authority. By the time the 1950s arrived, the first cracks in the lobotomy craze were appearing. New medications, most notably chlorpromazine, offered alternative treatments for psychiatric disorders, reducing the perceived need for invasive surgery. Public awareness of the procedure's consequences grew, fueled by survivor accounts, investigative reporting, and academic critiques. Nevertheless, thousands of Americans had already undergone irreversible surgery, and the psychological and social consequences reverberated through families and communities for decades. By the late 1940s, lobotomy had become more than a medical procedure. It was a social phenomenon in the United States. What had begun as an experimental neurological intervention in Lisbon under Egas Moniz had crossed the Atlantic and been transformed by Walter Freeman into a widespread socially sanctioned tool that both reflected and reinforced the anxieties of post-war America. Psychiatric hospitals were overflowing with patients, often with no realistic hope of treatment, and families desperate for relief turned to this surgical solution, willing to entrust their loved ones to the scalpel of a man whose charisma was matched only by his audacity. The social and cultural dimensions of lobotomy reveal a disturbing portrait of a society in which fear, stigma, and institutional imperatives converged to normalize one of the most controversial procedures in medical history. State hospitals, particularly those in the northeastern United States, were notorious for overcrowding. Institutions like St. Elizabeth's in Washington, D.C., Belchertown State School in Massachusetts, and the Willowbrook State School in New York were filled far beyond capacity, housing not only adults with severe psychiatric illnesses, but also children and adolescents with developmental disabilities or behavioral problems. Staffing shortages were severe. Nurses and attendants were overwhelmed, sometimes responsible for dozens of patients at a time, many of whom required constant supervision. Within these institutions, the promise of lobotomy was a seductive solution. If patients could be made calmer, more manageable and less demanding, the burdens on staff would be reduced and the institution could function more efficiently. It was a practical, almost bureaucratic imperative that often overrode ethical considerations. The procedure became not only a medical intervention, but also a method of social control within an institutional environment that prioritized order over individual welfare. Women were disproportionately subjected to lobotomy. Post-war American society placed enormous pressure on women to conform to domestic ideals of motherhood, marriage, and emotional stability. Women who deviated from these norms, whether through depression, anxiety, irritability, or what was then considered excessive independence, were sometimes labeled as mentally ill. Doctors and family members alike sometimes interpreted ordinary emotional distress as psychiatric pathology, a misreading that could result in institutionalization. Once in the hospital, these women were at risk of undergoing lobotomy, often with minimal or coerced consent. The procedure promised to transform them into compliant, manageable individuals, erasing not only symptoms, but also autonomy and personality. Diaries and letters from patients and their families describe profound anguish. Women who had once been articulate, expressive, and emotionally vibrant emerged after surgery flattened and emotionless, unable to form meaningful relationships, unable to work, and sometimes incapable even of self-care. The loss of agency was total, and the psychological trauma reverberated through families and communities for decades. Children and adolescents were not exempt. Reports indicate that some teenagers displaying behavioral issues, rebelliousness, or symptoms now understood as typical developmental struggles were institutionalized and subjected to lobotomy. For these young patients, the surgery was especially devastating. Their brains, still developing, were irreversibly altered, leaving many with permanent cognitive and emotional deficits. Families often consented under pressure, desperate to find a solution to what they perceived as dangerous or unmanageable behavior. In some tragic cases, children were returned home profoundly altered, emotionally blunted, and socially incapacitated. The procedure, originally intended for severe psychiatric disorders in adults, had become a tool for disciplining and controlling those whose behavior deviated from social norms, highlighting the troubling intersection of medical intervention and social conformity. Media representation played a critical role in shaping public perception of lobotomy. Newspapers, magazines, and newsreels often framed the procedure as a miraculous breakthrough, emphasizing cases in which patients appeared calmer, more manageable, or socially reintegrated. Photographs depicted serene, seated patients, their expressions suggesting contentment and recovery. Sensational headlines praised Freeman and other pioneering psychiatrists, framing them as heroes bringing relief to the mentally ill. Yet these images and articles masked a far grimmer reality. Emotional blunting, cognitive impairment, seizures, incontinence, and even death were common outcomes for many patients. Survivors' accounts, letters from families, and investigative reports paint a picture of widespread suffering that the media largely ignored. The public narrative created a veneer of legitimacy, making lobotomy appear both safe and desirable, while the lived experiences of patients and families revealed the procedure's devastating human cost. Within institutions, lobotomy functioned as a mechanism of control. Patients who were once expressive, resistant, or disruptive were transformed into compliant, docile individuals. Nurses and attendants found their workloads eased. Physicians could demonstrate measurable success through reductions in aggression or vocal protest. The procedure thus served both medical and institutional imperatives, aligning the goals of efficiency with the rhetoric of therapeutic benefit. Yet the cost was profound. Many patients lost the very qualities that made them human: curiosity, empathy, emotional responsiveness, and the capacity for independent thought. Families recounted waking to find their loved ones changed beyond recognition, their personalities erased by a procedure framed as a miracle cure. These personal tragedies illustrate the profound ethical failings of a medical system that prioritized procedural success and social expedience over human dignity. The procedure's expansion also reflects broader societal anxieties. Post-war America was a period of intense social conformity, with rigid expectations regarding gender, class, and behavior. Psychiatric institutions and physicians were not only treating illness, but also enforcing social norms. Lobotomy became a tool to manage individuals who did not fit the prescribed social mold. Those with chronic depression, obsessive tendencies, or nonconformist behaviors were seen not merely as patients, but as social problems requiring surgical correction. This conflation of medical treatment with social control highlights the cultural context in which lobotomy flourished. A society eager to normalize behavior through medical authority, often at the expense of individual rights. The psychological impact on patients was profound. Emotional flattening and cognitive deficits were common, often permanent. Diaries and letters from survivors describe a sense of alienation and estrangement from themselves and their families. One woman, institutionalized for chronic anxiety and depression, described feeling like a ghost living in my own body, unable to feel joy or sorrow, her relationships forever altered. A man who had undergone surgery for aggression returned home mute and indifferent, his personality erased. These cases illustrate the devastating consequences of a procedure that prioritized observable calm over subjective well-being. The loss of self, often ignored in clinical reports, was central to the lived experience of lobotomy patients. Ethical oversight, or the lack thereof, compounded the problem. In many states, informed consent was poorly defined or absent. Families were pressured to approve procedures, often without understanding the full consequences. Patients themselves were rarely able to refuse. Legal and regulatory mechanisms were insufficient to prevent abuse. As a result, thousands underwent irreversible surgery, often for conditions that were minor or poorly understood, leaving a legacy of trauma and injustice. Investigative journalism and academic critiques eventually exposed some of these failings, but only after decades of widespread application had left deep scars on families and communities. The cultural discourse surrounding lobotomy also reinforced its acceptability. Psychiatrists, neurologists, and medical journalists framed the procedure as a triumph of modern science. The language of control, efficiency, and rational management dominated, while terms like suffering, trauma, or identity loss were largely absent. Patients were depicted as subjects to be measured and managed rather than individuals with rights and agency. This rhetoric extended to education and public policy, influencing how society perceived mental illness and its treatment. Lobotomy was presented not only as a medical necessity, but as a moral imperative to calm, normalize, and rehabilitate those deemed abnormal. At the same time, some families and advocates began to question the practice. Letters, oral histories, and court documents reveal growing unease with the procedure's outcomes. Survivors described a profound disconnection from their previous selves, while parents and siblings recounted heartbreak at watching vibrant personalities reduced to blank, compliant shells. Ethical critiques from psychiatrists and philosophers questioned whether any perceived behavioral improvement could justify the irreversible destruction of a person's identity. These voices, however, were often drowned out by the medical establishment, media narratives, and institutional pressures that promoted lobotomy as a solution to social and psychiatric problems alike. By the early 1950s, the American lobotomy craze had reached its peak. Thousands of patients, men, women, and children, had undergone transorbital or prefrontal lobotomies, often with minimal consent and under circumstances that would today be considered ethically indefensible. What had begun as a radical experiment to alleviate severe psychiatric suffering had transformed into a widespread social and medical phenomenon, producing profound and often permanent human harm. The consequences, both moral and medical, were staggering, exposing the dark underbelly of psychiatric practice in mid-20th century America. The first signs of a moral crisis emerged as families, journalists, and some members of the medical community began to question the procedure's ethical foundation. Letters from relatives describe shock and despair. Mothers who had consented to surgery hoping for relief from their children's suffering returned to find their children mute, apathetic, or physically debilitated. Spouses reported partners who could no longer engage emotionally or intellectually, reduced to passive, compliant shadows of their former selves. Patients themselves, when capable of reflection, often expressed confusion and terror. One woman described waking from surgery to find herself like a stranger in my own body, unable to recognize familiar faces or experience emotions she once cherished. These personal accounts, though often silenced or ignored in clinical literature, painted a harrowing picture of human cost. Medical scrutiny intensified as reports of catastrophic outcomes accumulated. Physicians and researchers began documenting the profound cognitive and emotional deficits produced by lobotomy. Some patients exhibited complete emotional flattening, others developed incontinence or seizures, while a significant number suffered permanent personality changes or died due to surgical complications. Case studies highlighted that many individuals had been subjected to surgery not because of severe psychiatric illness, but for conditions that were minor, misunderstood, or socially inconvenient. This raised urgent ethical questions. Could the removal or alteration of brain tissue ever be justified if it irreversibly destroyed the essence of a person? And how could consent be truly informed in an era when patients were institutionalized, stigmatized, and powerless? The legal and ethical challenges surrounding lobotomy began to surface, though often slowly and unevenly. Some families initiated lawsuits against hospitals or individual physicians, citing malpractice, lack of informed consent, or wrongful death. Court records from the 1950s reveal families pleading for recognition of the profound damage inflicted on their loved ones. In many cases, these legal battles were protracted, constrained by limited understanding of brain function, the novelty of the procedure, and the considerable authority afforded to physicians. Nevertheless, these early challenges marked the beginning of broader ethical reckoning within psychiatry, as society began to confront the consequences of unregulated medical experimentation. The medical establishment itself was deeply divided. While many practitioners praised lobotomy as a triumph of modern science, others voiced sharp criticism. Prominent neurologists and psychiatrists highlighted the procedure's reckless application, emphasizing that its effects were unpredictable and often catastrophic. Scientific literature began to report cases of repeated lobotomies on the same patient, performed in attempts to correct or enhance perceived outcomes, further compounding harm. Critics argued that the very metrics of success, calmness, compliance, reduced aggression, were morally insufficient, as they ignored the destruction of personality, autonomy, and dignity. These voices, however, were often overshadowed by the popularity of Freeman'S techniques and the widespread institutional adoption of lobotomy as a seemingly practical solution to overcrowding and social disorder. The publication of books and articles exposing the human consequences of lobotomy intensified public awareness. Investigative journalists documented patients rendered nearly catatonic, families traumatized by irreversible losses, and institutional practices that prioritized efficiency over empathy. Photographs and case notes provided evidence of the procedure's devastating effects, challenging the sanitized narratives promoted by hospitals and medical journals. These revelations contributed to growing scrutiny of psychiatric practices, though significant change was slow, as lobotomy remained a standard treatment in many state institutions into the late 1950s. A particularly disturbing aspect of this period was the repeated surgical intervention on individuals. Some patients underwent multiple lobotomies when the initial procedure failed to produce the desired calm or compliance. Clinical records reveal cases where patients were reoperated upon with minimal consideration of cumulative harm. Each subsequent surgery amplified cognitive deficits, emotional blunting, and physical complications, effectively erasing any semblance of the person's prior identity. These instances exemplify the extreme consequences of applying medical procedures without ethical restraint or adequate oversight, highlighting a profound disregard for patient welfare. The catastrophic outcomes were not limited to adults. Adolescents and children, often institutionalized for behavioral or developmental issues, were subjected to lobotomy under the rationale of early intervention. While intended to prevent future psychiatric crises, these interventions frequently resulted in severe developmental impairment, emotional flattening, and permanent loss of autonomy. Survivors' testimonies describe confusion, fear, and alienation, as young minds were irreversibly altered by procedures performed without genuine consent. These cases underscore the broader social implications of lobotomy, revealing how institutional authority and medical ambition intersected to produce harm across generations. Freeman himself became a symbol of both innovation and hubris. He continued to perform surgeries, train other physicians, and promote lobotomy as a solution to mental illness, often downplaying the ethical concerns raised by critics. Public demonstrations, lectures, and media appearances reinforced his image as a pioneer, while the suffering of patients was largely invisible in these narratives. Yet within the medical community, awareness of the procedure's dangers was growing. Research began documenting long-term consequences, including loss of cognitive function, emotional blunting, and social incapacitation. This mounting evidence challenged the earlier claims of therapeutic benefit, revealing that the procedure's apparent successes were often superficial and came at the cost of irreversible harm. The international context further highlighted the ethical crisis. While European psychiatrists had expressed caution regarding Moniz's original leucotomy, the American adoption of transorbital techniques amplified the risks and scale of harm. Unlike in Portugal, where the procedure was applied selectively, Freeman's methods were implemented broadly, often in less than ideal conditions, and frequently targeted vulnerable populations. The combination of speed, accessibility, and institutional demand created an environment in which ethical oversight was minimal and the human cost was maximized. By the mid-1950s, a growing chorus of critics began to challenge the legitimacy of lobotomy. Psychiatrists, neurologists, ethicists, and social reformers documented cases of catastrophic outcomes, questioned the scientific rationale, and highlighted the absence of informed consent. Publications began to question whether any behavioral improvement could justify the destruction of personality and autonomy. Families of patients, armed with letters, diaries, and photographs, added emotional weight to these critiques, exposing the profound suffering hidden behind the veneer of scientific progress. Despite this scrutiny, the procedure remained in use for several more years, demonstrating the inertia of medical practices once institutionalized and socially legitimized. The moral catastrophe of lobotomy was inseparable from its medical consequences. Thousands of patients were rendered permanently impaired, some physically debilitated, many emotionally flattened, and almost all subjected to irreversible neurological changes. Clinical metrics of success, such as calmness or reduced aggression, often concealed the deeper human toll. Diaries, letters, and oral histories provide testimony to the profound loss experienced by patients and families, revealing suffering that medical reports systematically minimized or ignored. The very metrics used to justify the procedure highlight the ethical blindness of a system that valued behavioral compliance over personhood. Lobotomy also revealed structural weaknesses in American medicine. Hospitals, underfunded and understaffed, relied on the procedure as a practical solution to overcrowding. Physicians, motivated by ambition, recognition, and a belief in scientific progress, performed surgeries with minimal ethical oversight. Legal and regulatory frameworks were insufficient to prevent abuse, leaving vulnerable populations, women, children, institutionalized adults, exposed to irreversible harm. The procedure's widespread adoption underscores how social, institutional, and professional pressures can converge to sanction practices that, viewed retrospectively, are morally and medically indefensible. The era of lobotomy, which spanned from the mid-1930s to the late 1950s, left a profound and haunting imprint on medicine, psychiatry, and society at large. What began with Egas Moniz's experimental leucotomy in Portugal and escalated into Walter Freeman's transorbital lobotomies in America had transformed the lives of thousands of patients, leaving behind a legacy that is simultaneously medical, moral, and cultural. The consequences of these decades-long practices continue to resonate, not only in the lives of survivors and their families, but also in the ongoing debates about medical ethics, patient rights, and the limits of scientific experimentation. The end of the 1950s, lobotomy as a standard psychiatric treatment was waning. The rise of pharmacological interventions, particularly the introduction of antipsychotic medications like chlorpromazine, offered alternatives that were far less invasive and far safer. Yet the retreat of lobotomy did not erase its effects. Survivors lived with irreversible cognitive, emotional, and social impairments. Many could no longer maintain employment, engage in meaningful relationships, or live independently. Diaries, interviews, and oral histories reveal the deep psychological scars left by surgery, a sense of alienation, loss of self, and enduring grief. Families, too, were irrevocably affected. Parents mourned children who were still alive but fundamentally altered. Spouses faced partners whose personalities had been erased. Siblings and extended family members struggled with the emotional and practical consequences of caring for individuals diminished by surgery. The social consequences were equally striking. Lobotomy had reinforced the power of institutions over individuals, particularly the vulnerable and marginalized. Women, children, the poor, and those with developmental or behavioral differences were disproportionately affected. In many cases, the procedure functioned less as a treatment for illness and more as a tool for enforcing social conformity. Historians and sociologists have noted that lobotomy reflected the anxieties of post-war society, the desire to control behavior, maintain order, and manage difference through medical authority. The procedure's application was as much cultural as it was scientific, revealing how medical practice can be shaped by societal norms, fears, and prejudices. In the scientific and medical community, lobotomy's legacy is complex and troubling. On the one hand, it spurred research into the brain's structure and function, prompting questions about the neural basis of emotion, behavior, and psychiatric disorders. On the other hand, it demonstrated the dangers of medical hubris, the ease with which innovation can outpace ethics, and the catastrophic consequences when patient welfare is subordinated to scientific ambition. The thousands of lobotomies performed worldwide represent a cautionary tale about the capacity for harm when oversight is insufficient and ethical reflection is absent. Medical journals and historical analyses now view the procedure as an extreme misjudgment, emblematic of a period in psychiatry when the allure of quick, tangible results eclipsed the imperative to protect human dignity. The cultural memory of lobotomy is both haunting and instructive. Literature, film, and journalism have chronicled its horrors, ensuring that the human cost is not forgotten. The image of the transorbital ice pick, the vacant expressions of patients, and the clinical reports that glossed over trauma remain potent symbols of medical overreach. Works such as The Lobotomist by Jack L. High, as well as investigative articles in major newspapers and documentaries, have brought these stories to wider audiences, illustrating the depth of suffering inflicted under the guise of scientific progress. These cultural representations serve not merely as historical record, but also as moral commentary, reminding contemporary society of the perils of placing innovation above ethics. Legally and ethically, lobotomy prompted significant reconsideration of patient rights and medical accountability. While few early cases resulted in successful litigation, the widespread recognition of harm laid the groundwork for more robust frameworks for informed consent and ethical oversight in psychiatric practice. The procedure highlighted the insufficiency of relying on institutional authority to protect patients and emphasized the necessity of safeguarding individual autonomy, particularly for vulnerable populations. Today, discussions about experimental treatments, psychiatric interventions, and neurosurgical procedures are informed by the lessons learned from the lobotomy era, the importance of transparency, consent, and ongoing ethical evaluation. The personal legacies for patients are diverse but universally profound. Some survivors recount feeling permanently diminished, their personalities flattened or fragmented, their capacity for emotional engagement curtailed. Others describe a loss of creativity, ambition, or intellectual sharpness. Even decades after surgery, the sense of self remained altered, creating a lasting psychological and social burden. Support networks, rehabilitation programs, and family interventions have attempted to mitigate these consequences, but the damage is irreversible. Oral histories and survivor narratives underscore the human suffering that statistical reports and clinical studies often obscure, reminding us that the real cost of lobotomy was borne by individuals, not institutions or scientific prestige. The legacy of lobotomy also includes a broader ethical and philosophical reflection on the relationship between medicine and society. The procedure exemplifies how scientific authority can be mobilized to enforce societal norms, control behavior, and prioritize institutional efficiency over individual welfare. It raises enduring questions. How should society balance innovation with human dignity? To what extent should medical professionals intervene in cases of social or behavioral nonconformity? How can ethical oversight be ensured when scientific ambition and institutional pressures converge? The answers to these questions, shaped by the lessons of lobotomy, continue to inform medical ethics, research oversight, and psychiatric practice today. Globally, lobotomy's impact varied, but its lessons were similarly sobering. In Europe, Moniz's leucotomy remained a subject of ethical debate, while in South America, Africa, and Asia, variations of the procedure were implemented in select psychiatric settings. Across cultures, the same ethical concerns arose: the potential for irreversible harm, the difficulty of obtaining meaningful consent, and the disproportionate targeting of vulnerable populations. The universality of these concerns underscores lobotomy's significance not merely as a historical curiosity, but as a global ethical cautionary tale. Education and training in psychiatry have evolved in response to the lobotomy legacy. Medical, schools, and psychiatric programs now emphasize ethical decision-making, patient-centered care, and historical awareness of past abuses. The story of lobotomy is incorporated into curricula to ensure that new generations of clinicians understand the potential for harm when scientific curiosity outpaces ethical reflection. In this sense, the procedure's legacy, while tragic, serves as a critical educational resource, a stark example of what can happen when oversight, empathy, and moral responsibility are neglected. Cultural memory, survivor testimony, and academic analysis converge to create a nuanced understanding of lobotomy's impact. While some historical accounts attempt to contextualize the procedure within the limitations of contemporary knowledge, survivor narratives insist on the human consequences: lives altered, personalities erased, potential squandered. These stories challenge the notion that medical innovation is inherently positive, emphasizing the need for ethical vigilance, regulatory oversight, and societal engagement in decisions that affect the human brain and mind. The moral weight of these testimonies cannot be overstated, for they represent voices of those who endured irreversible consequences under the guise of treatment. The legacy of lobotomy also informs contemporary debates in neuroscience, psychiatry, and medical technology. Procedures involving deep brain stimulation, psychosurgery, and experimental psychiatric interventions are now approached with far greater caution, rigorous ethical review, and patient advocacy. Regulatory frameworks, informed consent protocols, and clinical trial oversight have all been shaped in part by the cautionary lessons of lobotomy. The procedure's history reminds clinicians and researchers that the potential for harm is not merely theoretical. It is borne by real human lives, and ethical reflection is not optional but essential. Public awareness campaigns, museums, and educational initiatives continue to preserve the history of lobotomy. Archives, medical records, photographs, and personal testimonies are curated to ensure that the lessons of this era remain accessible. The chilling images of operating theaters, the instruments and patient case files serve as both historical record and ethical warning. The narrative of lobotomy is now inseparable from broader discussions about the ethics of experimentation, the responsibility of medical institutions, and the moral imperative to safeguard human dignity. It is a legacy that challenges complacency, demanding reflection on the balance between scientific progress and ethical responsibility.